So more so we're looking at prevention of things getting worse. So this is a focus on managing deterioration in the acute heart failure patient and being able to understand what it's about. So the definition there is the rapid onset of symptoms and signs secondary to abnormal cardiac function. It may occur with or without previous cardiac disease. Now, since 2010, the definition focuses around your ejection fraction that you may get from an echocardiograph. So these echoes are done quite often in tertiary centres and hopefully in more regional centres now. So if your ejection fraction is greater than 50%, you are considered to have heart failure with a normal ejection fraction. But if it has a low ejection fraction, which is less than 50%, then that's considered to be without a normal ejection fraction. And that's how they define acute heart failure now. If you use a textbook which is perhaps older than 2010, the definitions won't be around ejection fractions, they'll be different to that. So keep that in mind if you're looking at different texts or different literature. All right, it has to be current. The second thing I want you to know about is that heart failure, acute heart failure, is a multi-system illness or disease, all right? And we have, over here, we've got heart failure on the top, but we have different organs around the place there. Over here, we have your heart. Now, I'll get my little pen out because I love to scribble everywhere. Okay, we have your heart over here, all right? So here's our heart. We also have it over this other side as well, but we're not going to discuss that so much right now. All right, so if you see our heart here, you can see that we have the nervous system very much joined to the heart, the autonomic nervous system, in fact, and you can see it comes here from the brainstem. Okay, now, one of the things that is being looked at very closely is beta blockers in heart failure, and you will see that what happens in heart failure, and this probably starts from the first episode, and if it becomes chronic, it often gets worse. But you can see this all here is nervous system involvement. All that is nervous system involvement, mainly the sympathetic nervous system. We also have some parasympathetic nervous system, but that affects more so the top of the heart rather than the ventricles. You can see the sympathetic is actually tuned in around the ventricles, which of course is the greater part of heart failure. Now, in fact, what happens with all this communication in the nervous system and heart failure is that we have what's called autonomic nerve dysfunction, and that in itself is a multi-system disease. You won't understand it just yet, but in fact, all of the nervous system, especially the sympathetic nervous system, becomes quite malfunctioning, and it dysfunctions, and it dysfunctions not just to the heart, but to the kidneys, to the peripheral vascular resistance, you know, how it affects the way that blood vessels constrict and contract. Okay, and what that means is that someone who has cardiac disease and probably an element of heart failure will have a different reaction in regards to the way that their vascular blood vessels react to stress. So the sympathetic nervous system and the stress response become quite dysfunctional. All right, so that's one take-home message. Hence, that's why a lot of these patients are on beta blockers. Okay. Now over here we have receptors in all sorts of other organs, and they in themselves become dysfunctional as well. I won't go into a lot of detail because autonomic nerve dysfunction isn't really understood, but it is certainly part of metabolic disorders such as diabetes, and it's also in people who have stress. Yeah, so we'll move on. So from that we take home that there's autonomic nerve dysfunction there, and we'll talk about it in our tutorial case in a little while. So now we'll move on to the next thing, and in here we're going to look at the fundamental equation of the circulation. All right, so pressure, flow, and resistance are the three things that are so important in how the circulation works, and you know that. Okay, so the pressure, so we've got mean arterial pressure over here. Flow is cardiac output, and resistance is your systemic vascular resistance. And systemic vascular resistance is the word that is given to how tight your blood vessels can constrict under particular circumstances, and it's called stressed blood flow. Resistance is measured in terms of dynes. So anyway, we'll move on. SVR, of course, is often reflected in what your blood pressure is. So if you have a blood pressure which is high, you often have a high SVR as well. All right, so let's look further down. There's cardiac preload, myocardial contractility, heart rate, and afterload. And these things here are the four main determinants of cardiac output. Okay, and we're going to talk a little bit more about those. And for those of you who don't like maths, this might be a bit difficult, but that's okay. We'll talk about it in concepts more so than mathematics, and try to apply it clinically so you understand it. So 3 ways to change blood pressure is you alter your flow, you alter resistance, or you do them both together. Who can give me some ideas about how we can alter blood flow? All right, now we've got volume, increased volume, yes, so intravenous fluids, yes. Now vasodilators is an interesting thing because in fact that's more related to resistance, because if you widen up the blood vessel, yeah, if you widen up the blood vessel, you decrease resistance. Okay, so increasing preload is like filling, so that will alter flow, yeah. Anything else? Yep, so vasoconstrictors such as noradrenaline, for example, will alter resistance as well. Suni? Okay, positive pressure ventilation, that's an interesting one. We'll look at that a bit further because that's quite complex. heart rate. Now, heart rate, what's that affected by? Heart rate does both, yeah. But it's certainly flow is your cardiac output, and cardiac output consists of two things: heart rate and what's the other one? Stroke volume. Very good. Sue? Okay. All right, so there's just some ideas there. Certainly you need to know that the mean arterial pressure, which is of course your systolic minus your 2/3 of your diastolic blood pressure, is equal to cardiac output, which is your heart rate times by stroke volume, times by your SVR, or your systemic vascular resistance. And that's difficult to measure, but it is estimated when you use various hemodynamic measurements. Okay, let's move on. Now, the next concept I want to talk about is the Frank-Starling cardiac function curve. Okay, you can see it's the dashed one there. Now, we have flow, blood flow. So this could be cardiac output on this side here. That's the y-axis. And on the x-axis, we have right atrial pressure. Now, what does right atrial pressure, what's that equivalent to that we might measure? Okay, your CVP, great. Which represents what in terms of cardiac function? Your preload. Good. Filling, right-sided pressure, yes, all those things, but the word I was looking for was preload. Yep. Okay, so let's have a look at this. Get rid of those lines. So we'll just think about this as your CVP, your right atrial pressure, and we'll think about this side as your cardiac output. Okay, so as the pressure increases in the right side there in the atrium, and there it goes, you can see it increases. What it does to blood flow, generally, it generally increases that. So as this goes up, which it does slowly, so does your cardiac output. So its cardiac output baseline there is about just under 3. And as your right atrial pressure increases to about, it flattens off, doesn't it? Flattens off till about 12. Yeah. You get an increase in your blood flow or your cardiac output. All right, so that seems reasonable. And the reason why it flattens off there is because you can only take so much volume to a point where the pressure will increase. So it's like the limitation of what something can hold will give you only a certain pressure. All right, so that's your Frank-Starling curve and the laws that surround Frank-Starling's curve. So preload, as preload increases to a certain point, you get increased cardiac output. And if there's the rising part of the curve, and then there's a flat part of the curve. All right, and they're things that will be important to talk about in terms of heart failure. Now we've got a venous return line. Now venous return is what returns to the right side of the heart. Say, for example, blood flow that comes into that right atrium is considered to be venous return. And there's lots of things that help that happen, and one of the factors is that you actually have to have blood flow for that to happen to start with. But also, you need to have a negative pressure. So when we do some deep breathing, what we tend to do is we tend to reduce the pressure in our chest. So when we take a nice deep breath, and you can all do it, nice deep breath, and when we get to the point where our chest is full of air, in fact what happens is that we have pleural pressure, which becomes very negative. And when the pleural pressure becomes negative, just before we take the breath, then we find that our chest area becomes negative. So you can see up here, so when we do that sort of breathing, our right atrial pressure actually goes right down. And you'll see this on CVP swings on people who have spontaneous breathing. But you can see that at the point where the right atrial pressure is the lowest, we actually have the highest flow. So that's venous return to the heart. So that makes sense, doesn't it? And as our pressure increases and the filling increases in our right atrium, the venous curve comes down. All right, so the reason why it comes down is because it increases in pressure, but the flow slows down, doesn't it? Yes, so when we take that breath, that deep breath to bring in some blood flow back to the heart, it starts with a high flow and then goes down to a low flow, and that's a venous return curve. Now, interestingly enough, there's an intersect here between this dotted line, which is preload, and the venous return curve. And this little intersection here, which happens just there, okay, is the optimum point in where this person needs to have their right atrial pressure in order to be able to have some cardiac output. So this particular person has a CVP here, or a right atrial pressure of about 6. And as you can see, in fact, you could keep increasing this person's CVP until they got to about 12. So this is someone spontaneously ventilating, no positive pressure or anything to get it. This is just simple physiology. So when you actually put those two things together, if you had someone who had a CVP of 6 and you gave them some fluid, extra fluid, their CVP would increase and it would actually improve their cardiac output. But then once it got past a CVP of 12, you would find that the cardiac output would flatten down, and in fact it would start to fall after a while. Okay, and that's when someone gets overfilled. All right, so that explains those things. You will see venous return curves in some of the articles you might read, and you will also see the Starling curve. And a lot of the hemodynamic monitoring we have actually does all these calculations for us, and we just don't know that actually happens. All right. So, interesting, isn't it? Preload. This is about preload and getting the optimum amount of preload to assist cardiac output. And you need to understand that to be able to understand acute heart failure. Now, another thing you'll see is these, I'll just take it one step further, volume pressure curves. Okay, so this is a volume pressure curve down the bottom, and it is actually a graphical presentation of systole and diastole in the left ventricle. Okay, so we've got several things happening. First of all, you've got your ECG at the top, And we've got a lovely QRS complex there, which is important because that seems to correlate with the grey line down there with your ventricular contraction. Then we've got your left ventricular pressure, and then you have your left ventricular volume here. So as the contraction occurs, your volume goes down, the pressure goes up in the ventricle. Okay, so that's quite easy to see in a contraction. Now, if you transpose that onto these curves down the bottom here, what you see here is you start here. That starts, we've got a contraction happening, so the pressure goes up, the volume gets less, which is down the bottom. This is volume down the bottom. Okay, so this is a natural looking curve. We've got systole here, and we have diastole around here. So diastole starts from this point here and goes down. Systole is when the pressure's at its highest. Okay, so that's how it looks, all right? And this area just here, and I'll just wait for it to come around again, this area across here is your stroke volume. Okay, all right, so that's fine. So let's just then look at the next one. If you increase your preload, what that will do, it will increase your stroke volume. If you increase your afterload, which increases the pressure up, that can decrease your stroke volume. Okay, so that's what it shows. So the dark grey comes back here like that. So increase your preload to a certain point, and you increase your stroke volume. Increase the afterload to a certain point, and you decrease your stroke volume. Okay. Now, contractility is also important, and if the contractility isn't strong, that will affect both your preload and your afterload. We'll look at the next one for that. So if you have systolic dysfunction, now systolic dysfunction is the ability to be able to contract, the strength of your contraction. What you end up with is a preload like that compared to normal. So you can see the stroke volume is actually quite less. So in fact, people who have systolic dysfunction, to be able to get the same amount of cardiac output, okay, cardiac output is equal to stroke volume times heart rate. In fact, if you have smaller stroke volumes, they're going to naturally increase their heart rate, aren't they? Okay. Now, systolic dysfunction is mainly seen in people who have quite a big floppy heart. So let's do a nice big floppy heart here. Mitral valve, is that? Yep. Regurg, yes, you quite often see, it's my very untidy big floppy heart. Yes, quite often you'll get that in mitral valve disease even. Yep, so totally. Valvular disease does have that. Okay, now we go over to diastolic dysfunction, and that's a completely different animal to systolic dysfunction, and quite often you will have a very small, tight little heart. All right, now when you get a small, tight little heart, it doesn't fill properly and it doesn't contract properly. And probably, if you think about it, it's probably the muscle in the heart here is very similar to just say, you know how you get a cramp in your leg muscle? You get a cramping leg muscle that is full of lactate, is probably spasming from different things, maybe a bit of ischemia, or if you've done some heavy exercise, or if you've rested it on something and the blood flow is ischemic to it, and you have this cramping leg muscle, what you find is it spasms and shortens in the fibers of the actual muscle. And that's what you get in diastolic dysfunction. You get this cramping little heart muscle. Okay, and you can see that the ability to be able to fill here, and I'll just intersect it up the top with the atrium and the ventricles. And of course the ventricle at the left side's meant to be a lot bigger, but quite often it's not. So you can see the filling area there becomes quite limited. So again, your stroke volume does reduce, and I'll show you. So in a sense, what happens is that the stroke volume, first of all, it moves upwards. So you can see how that's moved upwards like that. But it also moves across like that. So you actually end up with this much stroke volume compared to this much stroke volume in systolic dysfunction. So in fact, you end up with a smaller stroke volume in diastolic dysfunction, and of course then a very, very high heart rate if it's compensating. Then you get in systolic dysfunction. Sometimes you get people who have both, which makes it very complicated, but we'll try and keep them separate today so you can understand them a bit better. Okay, any sort of comments or questions about that? Okay, so let's hear some notes here about diastolic heart failure. So it's about the relaxation and passive stiffness in the muscle of the left ventricle, and of course it leads to elevated pressures, and you get symptoms of heart failure, of course, because your cardiac output is reduced. But what's interesting in diastolic heart failure is the ejection fraction, and the ejection fraction is greater or equal to 50%. You go, hang on a minute, how does that happen? Because we've actually got a smaller stroke volume. Well, in fact, the ejection fraction is worked out by looking, and I've got a slide in a minute which looks at an echo. We can see actually how it's calculated. But in fact, it's greater or equal to 50% of what's in the heart is ejected. And remember, the filling is actually, in the initial stages, is actually a lot less. Okay, and I'll talk about that in a minute. So filling is less, but ejection is greater or equal to 50%. And that's how the definition will present to you. Now in diastole, the heart just doesn't fill. It's much more complicated than that. And if you look down here in A, this is your left ventricle. You can see it's like a spiral of elastic fibers. So in fact it does a twisting action. It's a bit like when you twist something, it actually engages some energy within that twisting action. And then when you let it go, it actually tends to propel whatever is inside out. When it twists, it actually tends to draw fluid in, and when it twists out, it releases energy and propels fluid out. So the twisting motion in diastole is actually a really important part of cardiac output. And that coil or spring-like action is released in early diastole to produce ventricular recoil that leads to an annular motion and suction. All right. So again, there are things that affect the elastic nature of that cardiac muscle. All right, so this is essentially, they're looking at this through speckled tracking images, in other words, some nuclear medicine type of images, and you can see the arrows there of this twisting action within the left ventricle. And so subendicular and subepicardial fibres represent two oppositely directed spirals. So they twist, but things that will lead to stiffness is fibrosis or increased collagen. And some diseases actually make that worse, and you get a stiffness. And that stiffness leads to delayed untwisting, and that tends to be the basis of diastolic heart failure. All right, so, and it affects your preload, essentially. That's what it means. All right, it affects your preload because, and that's why it doesn't feel properly. Okay, so the preload is approximately your end diastolic wall stress. It's related to each other. So in a sense, if your heart isn't going to twist properly and have that sort of twisting, sucking action, it's not going to have proper preload. So that in itself means that your heart won't have its cardiac output eventually, will it? All right. Now, okay. So the Frank Starling mechanism is I won't go too much into this, but really what I want to say to you, we know the Frank Starling mechanism. And it's about diastolic ventricular filling is limited by the acute non-dispensable pericardium constraining filling the ventricles and by the cytoskeleton, okay? You know that. But what I want to point out here is there's a pressure called transmural pressure. Transmural pressure in the left ventricle, end diastolic pressure, that's what LVED stands for, accurately reflects the effective distensing pressure responsible for the length of the myocardial fibres. So we have this equation there, but that's what it really means. Now the transmural pressure you will see come up time and time again when we talk about how to relieve this tension on a diastolic heart failure, okay? All right, so there's some notes for you. But essentially, in the failing heart, the stroke volume depends substantially on the contractility and the afterload, which is what I showed you in those pressure volume curves. Okay, now there are several things that affect the contractility of the heart and the afterload. And one thing you need to be really up to speed with is something which is called ventricular-arterial coupling. Just have a look at the next slide. It doesn't, it just shows contractility. Okay. I'll just go on to this one here because I've got a bit of a chance to do some drawings. Okay, now afterload and ventricular-arterial coupling is an important concept for you to get, okay? Now, sorry, I've taken it too far. I'll go the other way. So, we've got your heart here. It's your heart. Oh, left ventricle, right ventricle, blah, blah. Okay, this is your left ventricle. And this is your aorta, okay, not that great. It comes back, and actually, yeah, okay, lovely. All right, so, and here we have the aortic valve, and we also have up here What are these little things here? What am I doing? Drawing these little holes here. Where do they go? Anyone have any idea? Got a pulmonary artery. Now pulmonary arteries are into the lungs. Now this goes to the body, the aorta, but pulmonary arteries would go this way, wouldn't they? They go back to pulmonary artery goes that way. Yeah, Jane's got it right. These are the coronary artery entrances to so your coronary arteries that go through the heart. Okay, so that's what supplies the blood flow to the heart, doesn't it? Okay, so you've got that. Everyone understand that? All right, so in here we've got coronary arteries. Now, for the heart to contract properly, and it contracts, it does that lovely circular motion. For the contraction to actually be really effective, we have to have, first of all, an aortic valve that works properly. Okay, and so it does that. So the blood goes whooshing down the aorta, and it tends to hit the side like that. And next week we'll talk a bit more about this, but we tend to get a reflective pressure wave that comes back up. Now, what's similar, can you imagine a boat going down a river? And as it goes down the river, you get these wave formations happening. And these waves hit the side of the bank, and then they reflect off that and they come back, and you find that as two waves join together, okay, we've got two waves, they come up and then they actually peak together, one coming the opposite way, and you will get sort of these higher waves forming, one reflecting off the riverbank as the other one comes towards it. Okay, so the same thing happens with reflective waves in the aorta. Now, as it comes up, that reflective wave, and it times just right the blood flow coming out of the aortic valve, what it does is makes the pressure in here quite lovely and high. So that actually then feeds your coronary arteries. So you have to have a really good reflective wave that's timed really well with your contraction to be able to feed your coronary arteries really well. Now, if you have that happen, what happens is that the whole thing works really well together. Now, what you'll find often in diastolic heart failure is that, and in fact heart failure of both systolic and diastolic, is that doesn't happen properly. So ischemia occurs from your blood flow to the coronary arteries. Yeah, okay. Okay, Sonia, you've got a question? Okay, so what was your question? What normally makes that wave? So what happens is, just like the riverbank reflects a wave off, you will have bifurcations here in your aorta. You will also have a build-up of atherosclerosis here, which will also cause a malfunction in that. So people who have a heap of atherosclerosis in their aorta will have really poor reflective waves, and hence they tend to get ischemic heart disease. All right. And we'll talk a bit more about that next week. Okay, yes, interesting concepts. But the arterioventricular coupling is the term that we use for the ventricular contraction occurring at the same time as we get all these things happening in the arterial bed that work together. Now, if that doesn't happen properly, what you end up with is a response which is called increased afterload. All right, so let's look a bit more at that. Now, we've got here your Frank Starling curve. It talks about contractility. Okay, so let's then talk a little bit more about afterload. So afterload isn't just your systemic vascular resistance, which a lot of us sort of define it as. It's actually, first of all, the tension opposing, or the force opposing, that fibre shortening in your ventricular ejection. So it's first of all your myocardial wall stress. So if you've got a stiff diastolic dysfunction heart, that in itself is an afterload to your left ventricle, because in itself it has to overcome that myocardial wall stress. Okay. All right, because the wall stress reflects the combined effects of central aortic and peripheral loading. So when I talk about central aortic and peripheral loading conditions, that means all those things that are meant to work together from the arterial bed and work in timing with the contraction. If they don't all work together, what they do is that they increase your myocardial wall stress, because it has to work harder to be able to get things to move forward in a cardiac output. So essentially, if you have acute heart failure, it's the afterload which becomes the decisive determinant of your cardiac performance. So all those things have to work together. So the wall tension is really what the afterload is measured as, and it becomes a pressure called T, and within that you have the radius of your ventricle. You also have the thickness. So if you have a very thick ventricle, you will have a high pressure, and we have TM here is the transmural pressure. Okay, now transmural, the reason why I'm talking about this is because when we talk about, Laplace law's got a lot to do with it, Kerry, thank you. But what we have here is that when we put on positive pressure, which we'll talk about CPAP in a little while, is that it affects this transmural pressure, and I'll talk a bit more about that. I don't want you having to remember and calculate all these things, but I want you to understand them, and often I put up an equation for you to be able to understand what's involved in things. So transmural pressure is equal to the intraventricular pressure minus your pleural pressure, and pleural pressure is increased by positive pressure in the chest. Okay, so that's how we'll talk a bit more about that. Now here again is some notes on ventricular-arterial coupling and a definition of them. It's the interaction between the ventricular and the arterial system, and it describes the transmission of the ventricular performance to the systemic circulation, and it's a very important determinant of cardiac performance. And the systolic function can only be evaluated in light of the afterload which the ventricle faces during systole. Okay, so if you have a very high afterload, you're going to have poor function. Okay. Contractility, some notes on contractility. It's the inherent capacity of the myocardium to contract independently of changes in pre and afterload. So intrinsic force is called contractility or inotropy, and that's why when we give inotropes, they do have that, is contractility and inotropy go together. Okay, right, so there's some notes for you. And of course, myocardial oxygen consumption goes up with the amount of work it has to do. All right, so hypoxia and ischemia stiffen the heart, and that in its way increases its afterload. All right, so in our case, which I'll talk about in a little while, we have afterload increase in someone who gets ischemic heart disease. So if you increase the oxygen supply to the heart, you actually reduce its afterload. That's what it essentially is saying. All right, now this is how they work out the ejection fractions. All right, so here we have an echo, and you can see here that we're actually looking upwards into the left ventricle. All right, that's what we're looking at. We've got contraction time starts with the white arrow. So the QRS complex starts there. So you can see contraction occurs here, and you can see the systolic time is there. All right, two grey arrows, one where the aortic valve opens and then it shuts, and then we have filling time. Okay. All right, so we have here we actually have the volume of the left ventricle in systole and the volume in diastole, and you can see in systole it doesn't empty right out. In fact, what it does is there's still a little bit left in there. There's 38 mils left, and when it fills to maximum, there's 70 mils. Okay, so the ejection fraction is worked out as a percentage of the total filling, and here we've got a heart which has an ejection fraction of 46%. Okay, so that's how it works. So if you're in diastolic heart failure, you're actually going to have a smaller ventricle and a smaller amount of blood, but the ejection will be smaller. Even so, it's a percentage, it's a ratio, so that's why it comes across as an ejection fraction which is a little bit higher. Doesn't mean the patient looks any better. It's just a ratio. All right. Okay, now essentially we have here, and this is taken from one of the chapters of acute heart failure, which I have put in your resources folder for you to have a read of, and especially important for you to read. You just might find it's a little bit more detailed and explains things a lot better than what your normal critical care textbook does. All right, so up here we've got cardiac performance. Okay, so that's your central thing here. Over here we've got preload, which we talked about, and you'll find we've got things that are important to preload, like your end diastolic volume, your diastolic ventricular index. Okay, so those sort of things affect your preload. You come back here, circulating volume, venous tone, end diastolic pressure of the ventricle. So all your filling depends on these things. You also have to have good ventricular compliance to stretch, and the things that affect that are fibrosis and ischemia. So essentially preload is about ventricular compliance, end diastolic volume. I'll get rid of all my drawings so you can actually read it. the end-diastolic pressure of the ventricle, the amount of volume you've got there, and your venous tone. Now, I'll just stop there for a sec. Circulating volume, that's really the only thing we can change with giving volume. And these is what we can do by giving oxygen. But all the other things, there's so many other things there that we can affect as well, but not through normal things. You can see venous tone, we might be able to affect that with some type of medication. Okay. All right. But giving volume isn't always going to increase preload. All right. So that's the take-home message there. All right. Let's then look at heart rate. And I talked to you earlier about the sympathetic nervous system and the sympathetic tone. That also affects your venous tone. It is also affected by your angiotensin, aldosterone, renin response to dehydration, low blood pressure, or maybe you have sympathetic tone, which affects it anyway in a autonomic nervous system dysfunction type of way. So that will affect both your heart rate and your contractility. When you take things like angiotensin ACE inhibitors, a lot of that is trying to block this off here. Okay, so that's your heart rate and contractility. Now let's have a look at afterload. Afterload's got a few more things there than you really ever thought. Now the first thing we have is the ventricular-arterial coupling, which I talked about briefly and tried to keep it as simple as possible, but it's actually very complex. And as Kerry said, it's Laplace law there. Now, the other things is the intraventricular pressure during ejection. So if you've got high pressures or a very stiff heart, it's not going to eject well. And of course, that will affect your ventricular volume. So we go further down, your aortic impedance. Now, if you've got disease of your aorta and other big blood vessel disease, such as resistance of your arterioles, compliance of your big arteries, volume in the arteries, and another thing there, blood viscosity. And of course, blood viscosity can be changed when perhaps we look at hematocrit in the blood or someone is dehydrated, the blood viscosity will change. But a lot of people who have aortic valve disease or aortic, oh yeah, maybe a AAA. I'm just trying to think of the word. When the aorta becomes tight and loses its compliance. It'll come to me. But aortic disease has a big effect of afterload. Now, resistance of the arterioles is your SVR, and that's affected by your sympathetic tone. So anyone who has a stress response to something like natural stress response will get your increase in the resistance of the arterioles. That's normal. But your aortic impedance and all these things too. So when we talk about afterload, it's just not this. It's all of these things as well. Okay. All right, so let's have a look at the question. You've probably got the answer there. So who has diastolic dysfunction? Someone with an anterior MI, diabetes, or systolic hypertension? In fact, the answer is all of the above. Myocardial injury results in passive stiffness. May also have systolic dysfunction, of course, but diabetes is something which it affects the epicardial base to the to your muscle in your heart, and that's why they have malfunctioning of that twisting action in your heart. Okay, so that's diabetes is a systemic disease. Hypertension. Now, so in a sense, you get myocyte hypertrophy, which leads to stiffness. Hypertension too is also a disease of your autonomic nervous system, and your reaction to stress response is such that it's hypersensitive. And as we see in the case we're going to look at in a minute, she has a history of hypertension. You'll find that anything that is of a small stress will result in massive hypertension, and it causes a massive ventricular-arterial dysfunction, and what you find is you'll get massive diastolic dysfunction and heart failure. All right, so also obesity there, sleep apnea. I'll talk a bit more about sleep apnea in a minute, which is the following valvular lesions causing diastolic dysfunction, and in fact all of them do. Aortic stenosis, that's the word I was trying to think of when I was talking about your aortic disease. It causes pressure overload and left ventricular myocardial hypertrophy, abnormal filling and relaxation, we know that. Aortic regurgitation leads to left ventricular volume overload and then a little bit of hypertrophy. Again, mitral stenosis restricts filling into the left ventricle, and regurg causes volume overload. But all of these things often come in a mixed picture. All right, so, okay, so there's some notes for you. That little arrow is meant to go down here with your coronary flow reserve. Remember I was explaining to you the coronary artery flow. Okay. Now the pericardial aspect of things is actually important too, because if your pericardium is actually tight, you can't have that beautiful contraction happening. It becomes so people with pericardial disease will have a diastolic dysfunction, which will turn into a systolic function over time. Atrial fibrillation causes loss of atrial kick, which also affects diastolic filling. Rapid rates do not allow for sufficient diastolic filling, and often you'll get the clotting, you'll get clot formation too, which will fill up the chambers of the heart. So you need to, that's why we have people like this on various anticoagulants. All right, now something I want to talk about, and I will want to bring it up. I'm just going to go full screen on this if I can. Oh, no, I've lost it. Excuse me for a sec. I've lost it, so I'll just have to find it again. Okay. Now I've gone to full screen, so I can't see anybody. But the reason why I've gone to full screen is so that I can show the detail. All right, so here we've got the heart. Okay, there's your heart. Yep, and I actually might change that to red so it stands out a bit better. You can see there we have the pericardium. Pericardium is here. It's a sac type of thing around the heart. Now, you can see how close the pericardium is to the pleura. See, the pleura of the lungs is this part here that goes right around the heart. Okay, around here. So that's your pleura. Oh, I've gone a bit sideways there. Okay, pleura. So the heart and the pleura and the pericardium are very closely aligned. Now, what that means is that when you breathe in and you become negative in the pleura in terms of pressure, around the pericardium gets affected too. What that means is that, and I'll just stop there for a sec, because I just want to show you that these blood vessels that come off the heart, we've got your pulmonary arteries, and they go, okay, pulmonary arteries, pulmonary veins, and your aorta. Your aorta's there. All right, okay, so when you take a deep breath in, and for example, someone with sleep apnea, what they do is that they don't have any breaths. They try to take breaths for perhaps and have a period of apnea for maybe, say, a minute or two, and then suddenly they take this massive, huge breath. Okay, and when they take that massive, huge breath, what happens is that the pressure here in the pleura, which happens to be right next to the heart, becomes extremely negative. And so when the heart contracts, it also puts pressure on these blood vessels going away from the heart. So when the heart contracts, it actually has very high pressures in these arteries that come off the aorta. So in fact, when someone with sleep apnea takes that huge breath to get some air, what they're doing is that they're actually increasing the afterload in the arterial bed to that heartbeat. And as such, over time, what that means, so when that heart contracts, the blood vessels are tight, it's got to work really hard. Now, if it works really hard, now I'm just going to go back to here now. When it works really hard, the heart, what happens to it? Suni? You increase its workload, yeah, and then what happens over time? You get hypertrophy. Thank you, Suni. That's great. So you get a very enlarged heart. So that's why people with sleep apnea get hypertrophy in their hearts, okay, because they increase the afterload. You can see this space here between the lung, the pleura, this is the pleura here, and the pericardium, and the left, and of course this is the same over here, and the left and right side ventricles are actually really close. Yeah. Now, when someone gets pulmonary edema, what you actually have is you have an increased hydrostatic pressure in the blood vessels in the lungs. Okay, so that has to be a reflection of the increased hydrostatic pressure from the heart. Okay, you understand that? So then what you end up getting is the interstitium fills up with fluid, and because it doesn't drain away properly to the lymph drainage, you get an actual alveolar flooding in the alveolus. And that's why in acute pulmonary edema you get all this fluid crossing the alveolus. And essentially what it is, it's a transfer of pressures and it affects the transport of sodium chloride and water across with alveolar edema. Now, I don't want to hear you tell me that water is forced in and out, because it's not forced at all. What it does, it malfunctions the transport mechanisms, and it's also about the fact that the pressures get too high in one place, and things flow from naturally a high to low pressure. Okay, so it's not forcing out. It's actually a very mythical type of concept that you will hear. Okay, so when you put on CPAP, so just say we've got -4 here, we take a deep breath. To be able to take a deep breath, we need to have a negative pleural pressure. So it goes from, say, -2 to -10, and we take, and air flows in. Okay, so there's airflow. And the reason why when we take in our lungs, our chest moves out, brings down the pressure, air flows in. Okay, so it comes from a high pressure up here to a low pressure in here. That's normal physics. And that's how we breathe. That's fine. Okay. All right, just say then, when we have acute pulmonary edema, to be able to, because the pressures are starting to build up here, we actually, and to be able to get the chest to be able to have adequate oxygen exchange, in fact, we have to move this down to, say, -12 rather than -10 to be able to get adequate breathing occurring. So that's why the work of breathing picks up, is because we actually have to move that pleura out to make a greater negative pressure. All right, so that's fine, but when we start to put on CPAP up here, what it does is it makes this +10 out here. Okay, so that becomes +10 there. Remember, that was essentially 0, and then we had -10 in here. Okay, so if it's +10 out there, what it means is that it actually works in a strange way around the pleura. So what happens is that this pleura becomes -10, which of course is the same as up here. Remember, we already had a minus score there, so 2 minuses makes a plus, doesn't it? So in effect, what happens is that the pressure in here becomes positive. Yep. Okay, so that's interesting. Now we have gas flow occurring because we have a small gradient here. So just say it was a small gradient of -12. Okay. But essentially what it means is within the chest and with the pleura, we have a positive pressure thing happening. Okay, so now the intraventricular pressure of the heart, and I've got this heart sort of drawn there, minus the pleural pressure, becomes your transmural pressure, and it's the transmural pressure which actually gets reduced. And when you reduce the transmural pressure, so your transmural pressure is the pressure within and around the heart, okay, is equal to your intraventricular pressure, and we might use, say, a CVP reading for that, which is a good surrogate. So just so we've got a CVP reading of 15, minus your pleural pressure, which is now 2 instead of 10, so it reduces down to, it reduces instead of increasing, okay? So instead of increasing, it reduces. So what we do there is we offset the pressure around the heart, Increased oxygenation, so we are on 100%, will relieve ischemia to the heart, so ischemia will be improved. But also by putting pressure around the heart there, what do we affect in terms of preload? What does positive pressure do in terms of preload? Decreases it. Yeah, good. All right, so in a sense what we do is, because we reduce the preload, we improve the contractility and we reduce the transmural pressure, so the ventricular pressure is less. We improve cardiac output. And all of that is related, I mean, we talked about preload, but the transmural pressure and the contractility all relate to afterload. Right. Now down here we've got the aorta. It comes through the chest down here, or down the middle probably, more so. But in fact, when the pressure is higher up here compared to down there, we get a natural flow of blood. Okay, and that in itself offsets some of the afterload.